I've been asked to speak on enhancing safety in surgery, mind over matter. As a person who has been always taking talks with a lot of references and academic talks, this was something very different. And I thought this is a good opportunity to share my experiences. So these are my disclosures, none related to this presentation. I am exclusively doing bariatric surgery from 2011. And this is the case mix as a matter of practice. I always show what surgeries I do. I think Kishore Anna has already mentioned about Professor Santokh Singh Anand. A special thing is that he became president of this association a year before I was born. And a man who had so much to deliver through PGI Chandigarh, he was the founder, director of that institution, that I am humbled by this occasion. And these are the illustrious predecessors in whose footsteps I am taking this talk today, and I am again humbled to list them here. Now, when we talk of surgical safety, typically all these things come in our mind. Is the surgeon well trained? About the protocols, checklists, consents, drug interactions, complication management, limitation acceptance, reskilling programs, and various things. But I thought, let's move beyond, because the topic says it's moving mind over matter. And the Cambridge definition says the power of the mind to control and influence the body and the physical world generally. So how does the mind controls the matter or the brain of a surgeon and his performance? Why mind matters? Because as surgeons, we are different than other doctors. We are the treatment both for safety, and we are also the cause of complications. So it's necessary that our mind is there to support our treatment, our efficiency, and avoid complications. So instead of talking academics, this time I'm going to talk more about what I have learned beyond the surgical skills from my mentors, from my peers, from my students, from my patients, from my personal experiences over a period of years, and this is what I'm going to share. So this started somewhere in 1979 when I was an anatomy student, and Professor D. Kumar, who was extremely unpopular in anatomy in Aligarh, used to say, "Doctor, can you tell me where the sural nerve, which compartment it will enter and which compartment it will go?" For something so dry like anatomy, to think and visualize how the nerve will transverse was almost impossible for us during those days. Because most of the other professors will teach us through mnemonics, where you just remember it, but you don't visualize. And this man created an environment where we could visualize through embryology how the anatomy will develop, and he made us a thinking doctor. And then my guide during my post-graduation days, Professor Iqbal Ali, we will have a very hectic emergency. Aligarh was a referral center from many districts, very hectic emergencies, and there will be appendicitis, acute appendicitis waiting. And he will say, "Just wait, we will operate, we'll decide tomorrow." And when the next day evening, by the time we are fully tired after post-operative rounds and all, post-emergency, he will say, "Raman, go and finish up all the 3 appendix now." And he will sit outside, wait till we finish them up. He made us learn how to manage a difficult case. He says anybody can operate when the patient comes in first 6 hours, but to operate patients after 36 hours is what you should get trained. And at that time, I thought it was unethical, but I realized that he was so closely supervising it to make sure that nothing goes wrong with the patient. And then I came to Mumbai, and I met my mentor, Professor Sri Khande. And many times we have discussed with him, and he asked me, "Raman, what have you learned from me?" And I always say, "Sir, I have learned the way you think." Obviously, I also learned the surgical technique, but I tried to learn how he thinks, how he takes decisions about patients, and I'm going to show you a few slides to show how it works. I think one of the strengths that I learned from his is communication and trust in the patient. So many times a patient will come who is willing for a surgery, has been told a surgery by 3 other surgeons, and he will say in Marathi, "You don't need this surgery." And then when the patient insists, he says, "Me operation tarnar surgeon ahe. I'm the surgeon who postpones surgeries." And he'll say, "Don't only avoid me, avoid all other surgeons who are like me, so that you don't get operated by somebody who wants to operate you." I remember a time when there was a mortality at Bombay Hospital, and Kishore Anna will remember that. This person who was a farmer, a leader, and after a cholangitis, there was a mortality. And this frail 5 feet 8 inches man would stand tall in the middle of 200 of his relatives, stand tall with his hands in his pocket, and without any fear of violence or abuses, and face the crowd. So he taught me how to take charge as the consultant in charge when chips are down, and don't push your juniors in front. He would always brief family after a surgery. Howsoever tired he is, he will go and meet the family in the room, and he will brief them about what happened. And the trust part, that he will operate patients in breech candy, and the payments, patients will make payment after 1 week or 10 days when they will come to his clinic. Not many surgeons will do that, but I learned that trust in the patient, and no patients ever defaults on such situations. This is one of his favorite quotes: "The more we sweat in peace, the less we bleed in war." So he would say, do a gallbladder with fundus first technique always, because those days we were taught that when you are in difficulty, do a fundus first technique. He says, but when you're in difficulty and you're doing a procedure which you don't do on a regular basis, you will struggle. But if you are doing it every day, when you are in difficulty, it's a cakewalk for you. So many times we drove from Srikhande Clinic, Dadar, to Bombay Hospital in the morning. I used to drive him, and he will sit next to me. He will have an atlas open in his hand, surgical atlas. And even at the age of 62, 63, he will go through anatomy in the morning. And he will make sure that the car radio is not on, and we don't do any irrelevant talk. It is only about the surgery. So the preparation and more preparation to avoid a complication. And then once there was a CBD injury in the hand of one of the person sitting on the podium, a dais here. And the very next case was also given to him, a very difficult gallbladder, because he says he's an excellent surgeon. If one injury has happened, that doesn't mean that he doesn't get to operate the second case. So that was the kind of confidence he had in his own team and in his own surgical colleagues. And then he maintained operation theater as a temple. There'll be absolutely no unnecessary chatter, movement, and distractions. And that is what we maintain even now in our own operating room, even after almost 30 years of working with him. So I learned from him that you work as a surgeon, think like a physician, but be a gentleman with your patients and their families. And I think they are great learnings for me. So from my peers across specialties, so once I was operating a patient in Wockhardt, Mulund, and this was a lady from USA who had a peritonitis in past, had an open surgery, and we were fully aware of it. And when we put an optical trocar, suddenly there was a mesenteric vascular bleed. Patient needed to be converted. Vascular surgeon also came in, and we transfused about 9 units of blood. Obviously, bariatric surgery was postponed. This gentleman, who was the CEO of the hospital, called me, and he says, "What happened?" And we discussed. He says, "This is generally multifactorial. Obviously, I know you are careful." So he got the records, and we found out that at that time, patient strained because the relaxant was less, and somebody entered the door and started talking to me, and there was a distraction. And he said that don't feel guilty. This was a multifactorial. He says accident never happens because of only one person's mistake. It happens when there are multiple. And I learned a lesson from Dr. Karanjikar, who, then this gentleman, my friend, Dr. Prashant Patnaik, he's a urologist. I used to go and operate in his nursing home, gallbladders during those days. And sometime it will be at middle of the night, 9 o'clock, 10 o'clock at night after my list. And I'll say, this is a difficult gallbladder, Dr. Patnaik, and all those things. And he says, Raman, you are an expert. Experts are not supposed to complain. You should deliver. I go to so many villages and do PCNLs and ureteroscopies. And I realized, and in so many situations when in workshops carbon dioxide got over, we used the suction machine outlet to inflate the abdomen. There was a power failure when I was doing a lap chole in 1994 in a village without generator. We waited for 1 hour for the generator person to come. And obviously, laparoscopic subtotal cholecystectomy became a standard of care in such situations. Dr. Rakesh Sinha, most of you would know, I saw his surgeries in his nursing home, and I realized that if he can operate from one side while the camera is coming from other side, I've been teaching in workshops that triangulation is so important, and suddenly I realized that if gynecologists can do ipsilateral suturing, why I cannot do it? And now routinely, we always do ipsilateral suturing, and triangulation is not a big issue as far as I am concerned. And this gentleman, a manager from ASICON Endosurgery, once told me, when we used to compare how many surgeries other surgeons are doing in town, he says, you don't compare with anybody else, your competition is only with you. And suddenly the things became easy and life became easy for us. So peace of mind is so easy. Once a patient from US came to Fortis Mulund again, and he refused to go under anesthesia till I come there. Once I reached there, he asked me, Doctor, did you sleep well last night? And he says, because I know if your surgeon has not slept well, your outcomes are not good. And I have put this picture when Morocco played France recently. My camera person, who may be here today, my first assistant, a senior surgeon, had not slept that night. And this definitely has an impact. From personal experiences, so many times in WhatsApp group we says, what would you do if it was my mother? This was my daughter who had acute appendicitis, and almost about 20 years back. And I had to plan her lap cholecystectomy. Those were the days when formalin chamber was a norm, even in corporate hospital. It took me almost 2 hours to find out where will I go get a sterile instrument to do a laparoscopic surgery, autoclaved instruments. And that day onwards, I decided what is good for my daughter is also good for the patients. So I think this is very important that we feel that way for our patients. I urge surgeons to listen to their own feelings and intuitions. I was operating in a bariatric patient in Fortis, Delhi, and we were reducing the colon. It was we did an open reduction, and then we did laparoscopic surgery inside. And as I was reducing the colon, I felt a give, and I told my assistant that probably I perforated the colon. And he says, sir, no, sir, I don't see it. I said, let's look at it, and we found it. Once in a gastric bypass, I perforated the posterior wall of the stomach. Again, the assistants were saying that they have not seen it, but I kept the instrument inside and we found the perforation. So these were the situations where I was right. And there was a situation where recently a patient had a GI bleed. She was stabilizing, but another expert whom I was consulting said, Raman, you should go in and you should do this. I listened to him and I forgot my own intuition, and we lost that patient because she never came out of anesthesia of the second intervention. So I think surgeons must respect their intuition. What you feel is most of the time right. Experts, listen to them, that's fine. Another very personal moment was, I was about to start a surgery on a patient from Kenya in, again, Fortis Mulund. And just when I was in the patient's room, in the preoperative ward, I got a call that my mother is no more. And no training has taught us how to face such emotional stress. And what do you do? So I told the patient this has happened, and I'm in no position to operate. I can call another surgeon. He said, no, I have come for you. Can you come back after 3-4 days? And I went back, completed the rituals, and after 3 days I came back and I operated her. So it's necessary that in stressful situations, you don't operate. Bariatric has been a very big teacher. Why this is a major concern? Because people think it's a cosmetic procedure. We know it's a supra-major surgery. The risk is more in the patient than in the surgery itself. And then there are compliance issues involved. We have been taught so little about obesity, how the brain and gut and liver all work together, and we need to understand that. I'll tell you 2 or 3 case situations. This young boy who was a schizophrenic was on drugs. He and his parents came to us. I spoke to his psychiatrist who says, I don't think he should get operated. We refused. After 1 year, they misinformed another psychiatrist, got a fitness, and the psychiatrist says, yes, you can go ahead. We operated, and 1 month later, patient became violent, had to be restrained in a psychiatric hospital, and it was a nightmare. So I think it's very important that you decide, even if you get a fitness, if you feel that this patient should not be operated, you should not operate that patient. This lady who was having a very low PO2 level on ABG, we operated in Bombay Hospital. We kept her for almost 1.5, 2 months we optimized. And even then, the oxygen PO2 level was 73, and the intensivist in Bombay Hospital said, you have to take a DOT consent and then only you can operate. And we operated her, and she became all right. So optimize, and then only you operate a patient. This lady was 82-year-old, 50 BMI. The intensivist and the family was insistent that don't tell the patient, please go and operate. But the patient was not willing. She said, I am already 82-year-old, I don't want surgery. We refused, and this is what is very important to realize, that patient's right is supreme. We are not operating on relative, we are not operating on intensivist. The patient's consent is probably the most important thing. This is a team approach. It's a huge team. This is the core team. And the multidisciplinary team approach, we have found 5 cases of mesenteric panniculitis after bariatric surgery because the physicians diagnosed, the radiologists diagnosed. We have found a patient who had thoracic duct blockage. We have done patients in post-pancreatitis as well. We have been in a lot of research in last 5 to 6 years. More than the number of publications, I see it as a mirror to myself, and I'll show you 3, 4 studies that we have done. We have done we have compiled data from 24 centers in India, over 11,500 bariatric patients, and we found that surgical mortality is only 0.16% in India. But more than that, we could divide it by patients who are doing less than 50 surgeries, more than 100 surgeries, and in between. And we found the complication rate in less than 50 surgery a year was 12.85% versus those who are doing more than 100 surgeries in 2.82%. So the conclusion was the learning curve in India is only about 50 surgeries for bariatric compared to 100 surgeries in US. And this became a major turning point in training of surgeons in India. Doing routine endoscopy was a routine for us, but till we analyzed our own data, and we found out 2% tumor rate in bariatric patients before surgery. And this made it mandatory for our patients. We also did an analysis of portion control eating, and we found that our results are better than, our results which shows the weight loss is better than most of the established centers worldwide, not because the surgery is better, because of the portion control eating behavior that our patients follow after surgery. And we are able to avoid mandatory 2 weeks liquid diet because our sonologist did a trial, measured everybody's liver size, and we analyzed it during surgery, and we could establish that most of the patients don't need a liquid diet, and we published it. So I think this is very important that you analyze your data, and it's a mirror to yourself. You see what you are doing, and you can improve your own clinical practice besides publishing it worldwide. So friends, we know what we repeatedly do that makes excellence as a habit, but it's not only the technical part, even your mental preparation is important. What is changing in surgical approach? A surgeon should behave like a service provider. We should be accessible, we should be efficient, and we should be affable. I remember my father, who was a thoracic surgeon, would not let patient stay in a room even for a minute. Those were monopoly days. One thoracic surgeon over half of India. But now we are in a different situation. The surgeon should be knowledgeable. We should not have an adversarial relationship with Google. Most patients will come well informed. We should believe that a well-informed patient is a safer patient, and you should be ready to accept that. And simultaneously, we should be more document savvy in terms of consent, in terms of risk explanation, in terms of post-operative visits, and detailed discharge notes. I think there is enhanced accountability on the surgeon's part. We should know how to live and breathe surgery. That will make us more safe. And to conclude, I think surgical safety doesn't begin or end in operating room. That's my family here in a place in Japan where we are all wearing those Japanese kimonos or dresses that are there. So what's important is to eat healthy, to exercise as a laparoscopic surgeon, meditate regularly so that you have a positive mind, and you make sure that your family is supporting you, household is calm and peaceful. So I think the mind over matter is summarized beautifully in this song. I don't really know how to sing it well. हमको इतनी शक्ति देना दाता कि मन का विश्वास कमज़ोर होना, खुद की जय करे हमको before winning others. So we should win ourselves, we should control our mind first, and then we will make sure that the surgery is safe and patient is safe. Thank you so much.